Hello and welcome to 24th October is World Polio Day. There are still a handful of polio cases in the world, specifically in Pakistan, Afghanistan and Mozambique, about 20 cases to be specific. But as it's pointed out more often than not, that even one case obviously is dangerous, and therefore polio has to be eradicated fully, as many governments indeed have taken this on head on. Now, very interestingly, just a few days ago at the World Health Summit in Berlin, many global leaders as well as countries have put down about $2.6 billion to end polio, and the larger objective being obviously to fight polio till it's completely eradicated. Now, in India, we've not seen a case of polio since 2011, and that's obviously some time ago. But the challenge obviously continues to remain, and while we've had successes like a sound polio vaccination program, eradication is something that must be on the mind. So, to understand this, the battle as well as what lies ahead, I'm joined by Dr. Mathew Varghese, consultant and head of Department of Orthopedics at the St. Stephen's Hospital in New Delhi. Dr. Varghese runs and has been running what is known as the last polio ward in the country at St. Stephen's. And St. Stephen's Hospital has a very interesting history in itself. It was started as a dispensary in 1876 and became a hospital in 1885. Dr. Varghese, thank you very much for joining me. So let me ask you, since as someone who's been treating polio and the outcome of polio, particularly the paralysis that it causes and the other or the crippling that we've seen in patients over the years, how would you see the battle so far, and what are we dealing with today?
Well, thank you so much for having me here for the World Polio Day news item. It's fascinating. Eradication of a disease like polio. When I was in medical school, we never thought it would be a reality. And today to see it as a reality is actually a thrilling experience, and also a humbling experience, that how science can change the world to the better of humankind. So that's a fascinating, feeling that we can do things once we determined to do things. So that's the first part. You feel good about it,
right? And how do you see this clinically, as in terms of what we've achieved? And I'll obviously come to the COVID questions a little later on, but in terms of what we've achieved and what we've learned, more importantly, from our vaccination efforts.
Polio, the story of polio vaccination is also historically a very important learning milestone in the development of vaccines. Remember, in the 30s and the 40s, US and Europe were reeling under various epidemics of poliomyelitis, and people were desperate for something, some treatment, some vaccine, exactly as people were desperate for some treatment, some vaccine in COVID. It's almost parallel the way it went. But at that time, medicine was not as advanced as we have advanced technology, advanced genetics research, advanced laboratories, advanced understanding of the biology, the epidemiology of diseases. So we were in the learning stages. So the first vaccine trial, which happened in the 30s, was a total disaster. There were many casualties from that vaccine trial. So from there on, we moved on to the vaccine trial for the injectable vaccine, which is a Salk vaccine, which came up. And then, of course, the oral Sabin vaccine, as it is called, the vaccine developed somewhere in 56, 57. Again, it is a lesson in international cooperation. The trials were done in Russia. So here is today we are having, a war situation. But then when you internationally cooperate and do things, when people were worried about a disease, you cooperate and help eradicate disability in a human being. So I deal with polio patients. Today also, I saw patients with polio. Yesterday, I had my operation theatre, I had a case with residual deformities from poliomyelitis, paralysis. And the only difference from yesterday and today is till a decade back, I was dealing with children with poliomyelitis. Now all of them have grown up. I deal with adults with poliomyelitis, but they are all paralytic poliomyelitis. And the challenge is they are more difficult to treat. And the understanding of surgeons for dealing with these cases actually has diminished substantially. So what happens is when a patient goes to a hospital or referred to a higher center, they don't know how to deal with it. So those are issues that we need to understand. The whole process of evolution of vaccine, for example, after the Salk vaccine was introduced, I think by 1956 or so, the global number of the American cases had dropped by even 85%. Huge reduction by 85%. But subsequent reductions were not by the total vaccination. Subsequent reduction happened by the economic development and safe water supply and sanitation.
Right.
So economy, safe water supply and sanitation, all three contributed to eradication, both in the US and in the Europe. It was not vaccination on a large scale that we have done today.
Right. And
there are learning points here.
Right. Go ahead.
Ask.
No, so I think a couple of questions. I think so. One is I wanted to ask a more general question. The reason that you as an orthopedic surgeon are dealing with polio patients more is because, and this is a question, is because the key impact of the disease is on the legs and hands and so on. Would that be right?
Yeah, predominantly it affects the legs, hands, legs first, then the hands, legs and the spine also.
Right. And
the important thing to understand is it is not that it doesn't affect upper limb muscles, the hands and the arms, it does. But usually if you have arms and legs getting paralyzed, the paralysis caused by the virus has ascended to your respiratory muscles. And once your respiratory muscles are paralyzed, you either need an iron lung, as was the deficiency of ventilators. In fact, the invention of ventilators was done because there was the need for iron lung in poliomyelitis. Just look at that. In COVID, you needed the ventilators. And those ventilators were created because of the ventilatory support required for polio patients with paralysis of the lungs. So look at in fact, I tried to draw in all the parallels between polio and, of course, there are huge differences.
Right.
But look at in the public at large, the suffering they had was very, very similar.
Right. Now, you pointed out to sanitation, and is that because this is a fecal-oral transmission? I mean,
absolutely. See, somehow you have to break the chain of transmission. So a person that is infected can carry the virus in the intestine. In fact, majority who have the infection, they just have a common cold, flu-like symptom. Again, drawing parallels with COVID, majority who have the infection have only common cold and flu-like symptoms without any serious consequences. It's only a small number that have paralysis. And the ones that do not have serious paralysis, they may be excreting the virus. Once they excrete the virus, it goes into the toilet and the sewage. How does a child get it from there? Either from flies or sitting on food items that are openly sold, sitting on the contaminated feces and going on to food items.
What is it then that affect you talked about the sanitation progress, economic progress, and of course vaccination, and you said the former actually had a greater role to play. So conversely, my question is, so why are we seeing these cases in Afghanistan or Pakistan or in Mozambique? Is that because the children are not vaccinated, or is it the other factors that you've mentioned?
I think all the factors contribute in these countries. These countries are poor. Poverty is the main. In fact, I treat poverty as a disease. The primary problem is poverty leads to malnutrition. Poverty leads to poor sanitation. Poverty leads to failure of access to safe water. And therefore, Malnutrition makes you vulnerable to diseases. Your unsafe water makes you vulnerable to diarrheal diseases and all other fecal-oral, related diseases. So I treat poverty as a disease, and we need to treat it. Unless we do that, I think the future of you may eradicate polio with a lot of vaccines and a lot of technological inputs and with a lot of billions of dollars being pumped in by the Rotary and the Bill and Melinda Gates Foundation and governments at large and CDC and UNICEF, all those pooled, WHO, all pooling their efforts together. But you've tackled one disease. So we have eradicated only one disease so far in our history of medicine so far, and that is smallpox. So polio is there. Yeah, there's just that bit away from there. But that bit is the final bit is a difficult part. So we need to work hard on all fronts.
Right. Now, Dr. Varghese, you mentioned that, you've seen patients today, you've seen patients yesterday.
And operated patients yesterday.
Sorry, you've operated patients. And these are really people who obviously are not young, but who contracted it before, let's say, polio was formally eradicated, but are still carrying the symptoms or rather the after effects of the disease. So why is it that they're coming so late to you, either in general and in specific?
Well, again, poverty is a huge contributor to this. And also the fact that they give up. We have to understand that the poor do things out of compulsion. And the rich have choices. So they can go and they can go to a hospital, they can access good health care, they can access things. But the poor, they try within the limits of their resources. For example, this patient came to me and he comes from far away. He's come from Jharkhand. If he's come from Jharkhand, he's taken a train journey all the way here. He's a married man. He has family back home. So if he's a daily wage laborer, how does his family survive? He cannot survive. His family cannot survive without an earning. So how does he get his earning? His earning is not there if he's not able to work, or he's running a street shop, or as he's a hawker, he doesn't go for his street vendor job. He doesn't get his earning. If he doesn't get earning for the day, his family is starving for the day. So they try within limits of their resources and capabilities, and then they give up. So when you really go into the details of what happened and when did they give up, it'll happen that they would have gone to a public hospital, would have been given a date for surgery, maybe would have been given a date for investigation. So he had to come on another date for investigation. Then he would have gone back and he would have come on for an anesthesia checkup. Then he would have gone back and come again for a date for surgery, no bed vacant, because beds are occupied by road traffic injury victims. And then he would have gone back. Each visit is 1 day's wage gone for these people. And no social support system takes care of that. The government does a lot of things it's amazing. Government does have a lot of programs, but these are details of actual human capacity problems. How much they can take on, how much can somebody support. So if you don't have a neighborhood expertise available, they go to the distance. So why is All India Institute of Medical Sciences having a crowd of poor people parked outside on the pavement? That's because the expertise that is there in All India Institute is not there in your district hospitals, is not there in your state regional hospital. All India Institute is now coming up all over the country, which is a good thing. But unless you have the capacity also in those All India Institute of Medical Sciences, you will continue to have people flocking into places where, there's a niche expertise like polio surgical expertise in my center.
Right. Now, how many patients do you think there are like this? I mean, like the kind you've just operated on across the country at this point of time?
My ward used to be full. I had about 16 beds, and it always used to be full. And patients used to be calling up regularly, sir, is there a bed vacant? Is there a bed vacant? They would be calling up. Today, post-COVID, things have changed completely. So I am a little apprehensive on this. Is it because they're afraid of coming to a general hospital and catching COVID and, facing the consequences of COVID? Or is it that they have lost their source of income? And I did a survey during COVID period, talking to person with disability and finding out what has been the impact of that on their families. And the number one impact was their loss of a job or worry for the next meal. So if that is the cause, they probably are not coming. So I have bed vacancies now, but the numbers that are coming now are less. But the patients are there, I know that. Because if you see in India, in the 90s, when I joined my hospital in 1990, there used to be 3,000 new cases of paralytic poliomyelitis in the city of Delhi alone. And it is guesstimated that all over India, there were 50,000 new cases all over India. 50,000 new cases.
This is
every
day,
I
or
haven't operated 50,000 cases, which means all of them are there out there somewhere.
so what is the periodicity? This is once in how many days, months?
Which one?
You said 50,000. Is it 50,000 a day?
Annual.
Yeah, sorry. Yeah, go ahead.
50,000 cases annually, 3,000 new cases annually in Delhi alone.
In Delhi.
So they are all there with varying degrees of paralysis. Many of them have accepted their deformity, they have accepted their disability and live on their life. So many of them come. I ask them, "Pehle kyun nahi aaye? Why didn't you come before?" "Sir, we didn't know." Or, "No, it was difficult for me to come because I would have to leave my family. And I couldn't do that."
Right, and from your perspective, what percentage of such cases, I mean, those who are clearly crippled by polio and those who are obviously crippled maybe a decade and a half or 2 decades ago, can be cured, and to what extent?
Oh, majority, of course, there'll be about 10%, maybe 15%, whom will need to be on a wheelchair for the rest of their lives. But even there, I can change the quality of their life by doing something. I still remember a patient was brought in from Kashmir. He could not even turn in bed. He could not even transfer himself to a wheelchair. So I told him, look, I examined him and I told him, look here, I don't want to name him. Look here, I can change small capacity of your daily activities by doing some tinkering with your upper limb muscles and changing some things for you in the upper limb muscle might help you transfer to a wheelchair and help you use your hands better. I did surgeries on his hands and his arm, and next time I was in Kashmir, somehow, I don't know how, some other patient of mine told him, I was in Srinagar, some other patient of him told him that Dr. Mathew is there in Srinagar at the Kashmir Institute of Medical Sciences doing a workshop for training doctors on clubfoot. He landed up with his whole family and bringing a shawl and walnuts and almonds for me. I said, please, this is embarrassing. He said, Dr. Saab, I could not transfer to a wheelchair earlier, now I can. Dr. Saab, I could not hold a cell phone. I could not hold a cell phone and talk. I had to keep it somewhere, get somebody's help, and then talk to somebody. Now I can hold a cell phone. These are life-changing things which you can do, but may not be able to walk. But majority of them, the only goal they have, and the parents also, when will my son or daughter walk? That is their concern.
Right. And I mean, this is really inspiring and motivational, Doctor. As you look ahead now, I mean, we've got all the learnings, as you said, and the very interesting synergistic developments between COVID and polio much earlier, and how one has contributed to the other. As you look ahead, how are you seeing your task? Not just as a practicing doctor, but also as someone who's contributing to the public health dialogue, and what are the things that we should be looking at or focusing on?
I think the biggest learning that polio gave us, like even today we are learning, for example, the vaccine-derived paralysis that is there. If the type 2 virus paralysis spreads in India, that could be catastrophic because the immunity for that is would be very low on a large scale. So we need to understand what is the strength of our population, what are the weaknesses, where are the weaknesses, and address those health issues where those weaknesses need to be addressed. So if the health, for example, uh, the genome of polio virus happened after I don't know how many years of the virus being identified. In the 70s, I think, 70s, the genome was identified. And the vaccine was generated before the genome was identified. In COVID, the technology was so advanced that we could identify the genome within the epidemic in Wuhan was November. The genome was published on a public site in January. Can you imagine? November, December, January. In 3 months, the genome was identified and put up for public use. So that whoever wants to do further research on this and can generate vaccines or do whatever, it's possible. So technology has made us that much closer to intervening more rapidly. So that was possible. But how many labs do we have that have that level of capacity? So tomorrow's world, quite understanding from the lessons from polio, the campaign when you could not do safe water, when you could not do the sanitation, you managed with a vaccine that is good. But the vaccine itself was contributing to vaccine-derived paralysis. So you are moving now to, you're planning to move now to injectable vaccines. Again, good, that's possible because we have those technologies. So when you evolve in your understanding of a disease, you evolve in your capacity, you evolve in your capacity to intervene, and your technology also has to evolve with it. So from iron lung, you need to you move to ventilators, which were an invention in a Danish intensive care unit. From iron lung in New York to a Danish ventilator. Today, modern ventilators are so advanced, so technologically savvy, it can do so many things. So we learn from past and we use our technological resources to the optimum and generate. For example, I went to an international meeting organized by WHO, and there it was a meeting on rehabilitation persons with disability. And in the meeting, there was this technologist who was looking at artificial intelligence and software development. He used from Italy. And he presented a fascinating paper which looked at technological innovations that are possible. Then at the end of the meeting, I asked him, how many such centers do you have in Italy? He said, we already have 6 of such centers. Now, for a small country with a small population, they have such advanced level technological centers. So tomorrow, if you are to follow the Atmanirbhar vision of our Prime Minister, we have to ensure that we develop the technological capacity in every region in the country, not just 1 or 2 or 3 or 4. No. Looking at our population, we can build that, and we should.
Right. And just to close off, Dr. Varghese, you talked about the vaccine-induced paralysis. So were you referring to the oral vaccines versus the injectable vaccines?
You don't have injectable vaccine is a killed virus vaccine. It doesn't cause paralysis.
Right. So
it's the oral vaccine that causes paralysis.
Right. So where are we on that today? And I mean, is that being eased out or?
Yeah. If you look at the number of vaccine-derived paralysis, they have also been going down, because earlier we were having more frequent national immunization days,
right,
where every child under 5 was being immunized with an oral polio vaccine. And these children will have the virus multiplying in their intestines, and they will excrete the virus. And some of these viruses may develop mutations and have the capacity to cause paralysis. These are known as vaccine-derived paralytic conditions. The number of national immunizations have been reduced now to 3 per annum. So the numbers have reduced. I think the total number globally is a very small number. I think still, whatever you see, in a very few countries you see them, and you do have the numbers that are there.
Right.
So this, we have understood this. Surveillance for this needs to be continued, but we move on to the injectable vaccine as time proceeds. But there are catches to the injectable vaccine. Logistically, it's more challenging to give it. See, oral polio is easy to deliver.
Yeah.
just an oral thing. You don't need a nurse injector, or you don't need a pressure injector. You don't need a technology for that. It's just a simple drop being given. But injectable, so you may lose out on access if you move to injectable. So you have to understand the dynamics of all this, analyze this, and take resourceful measures.
Right, and last question: as you look ahead, and you've already talked about the many lessons from the past and the present. What's the one big lesson for you, including from this whole period of COVID and our battle to make it endemic and of course eradicate it, from the lessons of polio that you've seen all these years?
The lesson from polio evolved over decades. And it gave us time. It killed less, but disabled many more. So it created a permanent repository of disabled persons in this world. COVID did not give us time. The biggest problem, I followed COVID very closely, and I recommended, I had some videos going viral on what should
I've
be
seen
done.
them.
I know that. But you know what was the problem in COVID? When you have such an overwhelming situation, you are on the mode of fighting a warlike situation. And even in that situation, you have to be a team. So all the doctors got busy caring. They did not have time to reflect. They did not have time to research. And they did not serious research that could come out with answers. So the important lesson that I would say, epidemiological research is research on populations and what happens to them. And human bench research is a different ballgame. But epidemiological research in pandemics and epidemics should be a frontline research program for governments. There has to be a huge prioritization for that. Unless we do that, and there should be, in fact, we do not have such appointments. There should be dedicated research. Only ICMR cannot handle with a limited number of staff. Every medical college should have, for example, in Harvard, in the Department of Orthopedics, there will be 30 faculty members, and about 10 of them would be just research appointments. Their job is only to do research. The clinicians are busy with clinical work. So COVID, everyone got busy with clinical work, caring, ventilator, doing, mundane care work. But serious analytical research, it should be dedicated to people that can do research as well as do clinical work. So you need to have a combination of the two. The high income countries come out with, and in fact, this is one worry that I have. Tomorrow, I don't know how many of you followed the research news that came up last month. Genetic editing to cure a person having, sickle cell disease.
Right.
Sickle cell disease. So that's a huge advantage. Genetic editing to cure a person having factor VIII deficiency. So the technology is there, the knowledge resource is there, developed in high countries, and tomorrow's world will be not drugs and pills and potions. It will all be genetic. So hypertension cured by genetic editing of some genes. Fracture healing by gene modification that stimulate bone formation. Future of diabetic treatment by gene modification to improve insulin production. And unless we are prepared to have research teams can develop such things,
right,
we will again be paying patent and expensive genetic medicines from West will be procured by us, and we'll still continue to be poor.
Right, and that's a very important and significant note to end on, Dr. Varghese. We've run out of time. Thank you very much for joining me. I do wish you all the very best in your work and your battle against polio, and I do wish many of those people who are still suffering are able to find their way back to your ward at St. Stephen's. Thank you very much.
Thank you.